Hello, I'm Dr. Guy Yatros from Dental Sleep Solutions in DS3, and welcome to Dental Sleep Medicine Insider magazine. Today we're going to talk about patients who have maybe improved their symptoms. They feel better with their dental device, but we do a follow-up titration test, and AHI isn't where we were hoping it would be. It may even be worse. Before we talk about what may cause this, let's make sure that we talk about testing our patients. There's two ways of testing our patients with HSTs and PSGs, but before we even consider testing our patients, the protocols we typically like to use are to make sure that the patient is wearing the device all night long, that their symptoms have improved. In other words, they're snoring, their Epworths are better, that they're wearing the device all night without any discomfort, because we don't want to test them if we think that the device may need to be adjusted some more. And we feel like they're overall improving. So once we have those things checked off, we can go ahead and decide to get a test. We work with our physicians to get these in various ways. But if we're going to do a home sleep test, which is often the way I prefer because it's a little more well tolerated by the patients and the patients will more likely follow through with this, we have different ways of doing it. What we used to do is we'd give them the test one night. They've already been titrated now for their symptoms to where they feel like they're doing well, and we think we're at the right position. We send them home for home sleep test. But maybe the AHI isn't where we were hoping it would be. It's not improved enough, or maybe it hasn't improved at all. Well, then we titrate them some more over a few weeks, then test them again. And we can repeat this process, but that can be laborious and take time, and sometimes the patients kind of get annoyed with the whole process. So the way I prefer to do a home sleep test, if possible, is to have a machine that will allow us to do more than one night at a time. So the patient can take the machine home and wear it for 2-3 nights in a row. And then that's a really more ideal way of doing it. And so what we do with these patients, again, they think they're doing better. They've already been titrated for symptoms. We go ahead and have them wear it where we hope the device is working well from their symptoms. So they've moved whatever far forward to where their Epworth or snoring seems to be improved. And that first night they wear it right there. If we do a 2-night test, then we're going to move them pretty rapidly forward the second night, maybe towards 70-80% of their maximum protrusion. But in an ideal world, like I have here on the screen, you can see that we might have a test that allows us to do 3 nights in a row. So the patient's going to move the device maybe 60-70% of their maximum protrusion the first night, and the second night they're going to rapidly advance it to as far as they can tolerate it, and we agree on before the test, maybe to 80-90% of their maximum protrusion. Then what they're going to do is back up the turns that they did between the first and the second and third nights back to where they've been wearing the device comfortably for quite some time. Then we get the results back, and now we can look, if you have something like DS3 software, you can see this patient went from 29 to 19 to 8 to 6 AHI, the 29.5 being their baseline. So those other 3 nights are the ones 19, 8, and 6, and we can make a decision pretty rapidly. We also want to look at the SpO2 readings as we're making this decision, and we can see that they improve. Well, you know, we're talking about maybe that they didn't improve. So we'll get to that in a second, but the other way of doing this is that you can actually have the patient go to the sleep lab. If you do this, you need to work with a sleep lab that you talk to regularly and you have protocols in place. The patient needs to bring their key with them to adjust the device, and we're going to agree on how many turns we're going to turn it each time that the AHI on a patient reaches a certain level. So typically it'll be that the AHI is above 10. The technician will come in and adjust the device, or most of the time they don't want to do that. We'll have the patient do it when the technician wakes them up, and they'll advance the device pretty rapidly, typically a 0.5 millimeter at a time, and they do this about every 45 minutes until we reach the AHI, or until we reach the end where we've already told the patient and the technologist that they can, as far as they can advance it. So again, we might make sure that we're doing our tests accurately and correct before we start saying, wow, why is the AHI off? So back to the question at hand. What happens if we do everything right? We have our 2 or 3 night test at home, we do a PSG titration or what have you, and the AHI is still higher or not any improved, even though the patient's feeling great. The first thing I always look at is to make sure we're comparing apples to apples. If the test that they took originally was old, the PSG maybe 7, 8, 9 years ago, the AHI could be worse. Also, we want to make sure that if we're looking at a baseline test that was a PSG compared to an HST or vice versa, there is certainly a possibility that could be the answer. I like to do PSGs to HSTs and HSTs to HSTs when we're looking to apples and apples. And so that could be the answer. Look how old the test is. And if we question the validity of the baseline test because of the age or other issues we're going to talk about in a little bit, then we might want to do a new baseline test in conjunction with our titration so that we know that we're really comparing apples to apples. Another big one that happens is people gain weight. So even if the test was only a year and a half ago or 2 years ago, maybe they gained 15, 20 pounds, which can make a notable difference in the levels of apnea someone will show during a follow-up titration study. So that's one of the reasons we always weigh our patients when they come in. We look at the previous notes from their medical doctors of what their weight was, and we discuss that. And that could come into fact. And again, we might want to do a new baseline test if they haven't gained a certain amount of weight. And then here's the one that's really not going to sit well for a lot of the dentists because we like exactness. But, you know, sleep testing isn't exact. It can vary depending on if the patient sleeps on their back, how sleepy they are, if they drink alcohol, if they have any allergies or something that night to where they can't breathe through their nose, and even the sleeping conditions. So you go sleep in a sleep lab, you may not sleep as well. So what happens if they went to the sleep lab for their PSG and they just didn't sleep well because they were asked to go to bed at a time that they're normally not used to? Maybe the temperature wasn't the same. They got people watching them. It may underestimate the apnea at the baseline, and they may actually, and if you do follow it up with a HST, it could certainly have very widely different results. So it could just be different because it's different. One of the home sleep testing companies we've worked with in the past said that on a 3-night test that they find as much as almost 5% of the patients who test mild to moderate on one night with the same equipment, same patient, same home, on one of the subsequent nights will be severe. So the AHI can vary per night, you know, from a mild case to a moderate with no treatment at all in place because people just sleep differently each night. And then, you know, this is the other one that doesn't sit real well with dentists. Some of the times dental devices don't work. I don't know the exact number. I think there's varying theories on that, but I usually say maybe 10% of the patients just don't respond well to dental devices. They just don't seem to open up their airway, and in some cases it actually makes their airway worse. It's hard to believe we pull the jaw forward and it doesn't open up the airway and could even make it worse, but in some cases it can. So at some point you have to decide, this is the best I can do. We write our letters to our physicians saying that, you know, we feel that this is as open as airway as we can, and maybe this isn't a good treatment for the patient, considering all else that that they're involved. We have to consider other ways of treating the patients. And then I think near one of the last things I want to talk about, this is not an exact science. Again, per night variances, jaws move differently. If you have a device that the patient allows the patient to open their mouth, maybe adding elastics may help, or maybe one night they open their mouth and the next night they didn't. And so it's just, it's not as exact as cutting a crown prep or doing a endodontic procedure or a lot of the other things we do in dentistry. And that's one of the things we just got to kind of get over. And the last thing I'll mention is really doesn't matter. And I don't mean this to say that it doesn't matter, but we have to ask ourselves in this particular patient's case, is this highly important? And there's two goals of treatment that we have for our patients. One is to make their symptoms better and improved, and the other is to decrease their AHI, in other words, to get more out of their lungs so they'll be at less health risk. And if we look back at the Wisconsin sleep study that they've been doing for over 20 years, as you look at the survival rates of over 1,000 patients over 20 years, we can see for people who have mild apnea, the AHI between 5 and 15, you know, yeah, there's a difference between healthy and people who don't have apnea, but maybe only 4% difference. So if someone has a AHI of 9 and they feel like $1 million and you test them and now they have an AHI of 12 and they feel like $1 million, well, you know, we'd like to get it lower than that, but really is it that crucial for this patient? Because maybe symptoms was their driving factor. Now we contrast that to someone who has an AHI over 30 and they remain over 30, you can see the survival rates for a patient after 20 years is 57%. So there's a huge difference there. So in that particular case, it would certainly matter. So we have to talk to our patients, and one of the things that's key here is when we sit down and we have a consult with our patient, long before we begin treatment, we talk about the 3 goals of treatment. We tell our patients, look, we first of all hope you're going to wear this device. We know that you have a better chance of wearing it than CPAP in most cases. If you wear it, we're going to hopefully improve your symptoms. And if that goes well, then we're going to hopefully be able to measure the breathing, and we can tell you from a health standpoint you're better off. And sometimes if we go through that with our patients, really all they care about maybe is number 2 there, is that they want to quit snoring. And maybe their AHI is lower. It's not that critical that, that we beat ourselves up getting from an 8 to a 4. for that particular patient. So the objective success is important. Also, I want to end by saying there's more to life than AHI. We also need to look at those SpO2 readings. I personally prefer to make sure we try to get our patients to where they're not desatting below 90%, really at all, but 1% or less is kind of our standard goal depending on the levels going into it. So let's don't just concentrate on AHI either. Let's look at both AHI, SpO2 readings, the patient's symptoms, and overall, I think you'll find that that some patients we think are failures, maybe they aren't, because we're not looking at really what's appropriate and needed for that particular patient. Well, I hope that helps you with some of the challenges in dental sleep medicine when the symptoms are better, but the AHI is still not where we want it. Thanks for tuning in and listening to my video here on Dental Sleep Medicine Insider magazine. Hope you enjoy the rest of this issue. We really enjoy helping dentists and their practices succeed at dental sleep medicine here at Dental Sleep Solutions and DS3. Thanks.